Please start.
Very good evening to every one of you, all the delegates present. I welcome you all on behalf of Jogo Health to the very interesting and a novel topic as the International Speaker Program on Breakthrough Treatment in the Management of Migraine. We have with us various faculties and eminent doctors present in this forum. I am Dr. Ruchi Shah, Senior Medical Advisor from Jogo Health. I'll just like to take you through Jogo Health, glimpse of the Jogo Health as a company. It is a digital therapeutics company which has developed the Jogo device. It is basically a US-based company headquartered in New Jersey with clinics in USA, Canada, India, and Malaysia. It is a J&J, that is Johnson & Johnson J Labs company. The key characteristic features of Jogo device are it is portable, non-invasive, and digital. And thus, it is a new age digital rehab with multiple patient benefits. It is an AI-driven device with a variable sensor applying the principle of EMG biofeedback, which facilitates neuroplasticity. And it is 510K exempted by the US FDA. So thus, since it facilitates neuroplasticity, it provides basically a real-time audiovisual feedback to become aware of the dormant or the overactive muscles. And thus, it works by tapping into the principle of neuroplasticity, the natural neuroplasticity in the brain, and it does remodels and reorganizes itself around the damage. So that is the characteristic and distinguishing feature of Jogo therapy. The clinical solutions provided are in the therapy area of neurology, urology, and gastroenterology. With neurology, it covers various indications like spasticity, focal dystonia, Parkinson's tremor, migraine, and chronic low back pain. Urology consists of urinary incontinence, voiding dysfunction, pelvic organ prolapse, erectile dysfunction, and vaginismus. And gastroenterology covers the disorders of dysenergic defecation, fecal incontinence, and chronic pelvic pain. Giving you the overall idea about the flow of today's presentation, there will be opening remarks and the introduction of speaker, moderator, and panelist by Professor Dr. B.S. Singhal, sir, followed by which there will be a presentation, a very nice, innovative presentation on the breakthrough treatment in the management of migraine by our international speaker, Dr. Caroline Bernstein-Mann. Subsequent to that, there will be a panel discussion moderated by Professor Dr. A.V. Srinivasan sir and the other panelists on EMG biofeedback in the management of migraine. And subsequent to that, there will be vote of thanks by Mr. Charles Jesudesan, who is a country head for Jogo. With this now, I would like to introduce our esteemed chairperson, one of the eminent personalities, man beyond introduction and a legend in himself, Professor Dr. B.S. Singhal, sir. He's a director of neurology from Bombay Hospital Institute of Medical Sciences, founder of IAN, recipient of several prestigious awards and accolades, including the Padma Shri by Government of India, Dr. B.C. Roy National Award, Wokhard Award for the Medical Excellence, and the Dhanvantri Award. He has published over 200 papers in the national and international journals, member of several international societies, including the AAN, ANA, BNA, and the FNS. And his therapy area of interest consists of multiple sclerosis, immune disorders, and Parkinson's disease. So with this, now I hand over the session to Professor Dr. B.S. Singhal, sir, for taking us through the initial remarks as well as the introduction of the panel. Over to you, sir.
Ruchi, for your kind introduction. Greetings to all. And I'd like to thank Jogo for bringing in this new device for this very common condition, migraine. I don't think I have to tell you much about migraine. It is so common that I think about 10 to 15% of the population suffers from it. It can affect, of course, our quality of life. It can make us also lose days of work. And there is no cure. But I think any new breakthrough is always very welcome. And today, for this, we have also the introduction of a new device, which has been also, I think will be spoken about by our esteemed international speaker. Can we have the introduction?
Yes.
We have Professor Caroline Bernstein, Professor of Neurology at the Harvard Medical School in Boston. She's the Levine Family Distinguished Chair in Neurology at Brigham and Women's Hospital, the author of Migraine Brain, Your Breakthrough Guide to Fewer Headaches and Better Health. And of course, our interests are migraine disorders, hormonal headache, and the use of integrative therapies in the treatment of headaches and pain. And thank you very much, Professor Bernstein, for sparing your time to give a talk to us today. We also have the panelists, and the moderator is Dr. A.V. Srinivasan. Everybody knows him. He was the president of the Indian Academy of Neurology, and he's very well known. He's also been at the Madras Medical College, professor emeritus from the TNMGR Medical University, a famous university. We have also the panelists, Dr. Lakshmi Narasimham, whom you all know from the Madras Neurology Institute in Chennai. We have Dr. Bahari Ghosh, who is a senior neurologist at the Bellevue Clinic in Kolkata and a very well neurologist. We have Dr. Nandan Yardi, who is very well known for his work on epilepsy, and he's a senior neurologist in the Jahangir Hospital, Pune. And we have Dr. Anshu Rohatgi for our capital city, New Delhi. He's a senior neurologist at the Sangh Gangaram Hospital. I think I'd like to now, not stand in your way, I'll request Professor Bernstein to give a talk on the topic of the EMG biofeed breakthrough treatment in migraine. Professor Bernstein, please.
Thank you so much. I'm so honored to be here. So I am speaking today, as you've heard, on breakthrough treatments of migraine. Thank you for that lovely introduction. I appreciate it. So 218 million people in India suffer from migraine, as we just heard. It's a huge percentage of the population. In the US, the number is about 40 million people. We have a 3-to-1 female to male preponderance in the US, 60%, so a little bit less in India, but clearly a significant burden of disease in both locations and really worldwide. So I'm going to start by just defining migraine, and I'm speaking to colleagues who I know are familiar with this. These are the ICHD3 criteria, and I think it's particularly useful because we know so much now about migraine pathophysiology, which really drives treatments such as EMG biofeedback, as well as some of the newer medications that I will speak about first, so that we can really think holistically about how to best treat these people and minimize the burden of disease. So to make the diagnosis of migraine, patient needs to have had at least 5 attacks. They have to fulfill these other criteria. So on the evaluation of somebody who presents to one of us with a new headache, even if it sounds like a migraine, we can't actually diagnose it till we've ruled everything else out, and the person has had at least 5 attacks. So the headache must last between 4 to 72 hours, and that's untreated or treated unsuccessfully, and it must have at least 2 of the following 4 characteristics: a one-sided quality, and I'll pause here and remind all of us that the word migraine comes from the Greek hemicrania, half the head. So you can see migraine coming right out of that. An interesting historical fact, there were descriptions of headaches that comport perfectly with migraine that are as old as 2,000 years in ancient Greece. So these headaches are not something new for sure. The headache must be one-sided, as I said. It must be unilateral. It must have a pulsating quality or a throbbing quality, and the intensity of the pain must be moderate to severe. It generally will get aggravated or by physical activity, walking, climbing stairs. We all know our migraine patients prefer to lie comfortably in bed if they can in the dark and the quiet. And during the headache, patients either will have nausea and or vomiting, or they'll have light and sound sensitivity. Some of the earlier research that I've done was looking at photophobia and how migraine eyes conduct light differently than the retinas of people who do not have migraines. I'm not going to divert into that today, but clearly the photophobia and the phonophobia are physiologic. And then this is true of all migraine diagnoses. At the bottom here, it must not be accounted for better by another ICHD-3, International Classification of Headache Disorders 3, diagnosis. So in other words, a post-concussive headache can look very much like a migraine. The headache with a sagittal sinus thrombosis, let's say, can look very much like a migraine, but these are rule-outs. We must make sure for our patients that they do not have anything else going on. So this is a primary headache disorder. The variants are fairly well described as well. So patients who have migraine with aura can be different. They may see the scintillations or the spots prior to the headache. Patients who have a hemiplegic migraine, where they may actually become paralyzed on half their body, very frightening, can look like a stroke the first several times. We can do genetic testing for that. An acephalgic migraine, an older term, but those are patients who get the aura, let's say, without actually getting the pain of the headache. So a little bit different. And then the chronic migraine that I think those of you colleagues who treat these patients with chronic migraine, it can be very difficult. That's a migraine where a patient will have a headache at least half the month, and 8 have to meet those migraine diagnostic criteria. And what Dr. Shah was saying at the beginning, these changes, this neuroplasticity and pain, what we're all interested in doing for our patients with pain is to interrupt the pain loop. And so we're looking for ways to do that. So when we assess our patients, we get a history of the phenotype. So try to describe the migraine. We want to know what the frequency is. 1 migraine every month is very different than 15 days out of the month. Is there a family history? We know that migraine is genetic. So would that make a diagnosis? It would not, but it's helpful information. And eventually, again, as Dr. Shah mentioned a moment ago, we will eventually have biomarkers. She didn't say this, I'm saying this part, but we'll have genetic testing where we'll be able to prove that, yes, this is a migraine. It's not just a clinical diagnosis. We all do a neurologic exam because we are neurologists, and we assess the need for imaging or further workup. I think if someone has a first new and worst headache, any red flags, we're all aware of these, that would indicate the need to do some further workup and imaging. So then we get to this point, and this is what I'm particularly interested in discussing today, and I'm very honored to have the chance to do so. Are we going to use medication? Are we going to use integrative non-pharma therapies, or are we going to use both of these things in combination? And how are we going to actually think about that? So again, I've mentioned before, we have no biomarkers to predict response yet, but we will. We think about the ecology of the patient. Are there comorbidities? Is this a patient with hypertension or anxiety? Do we want to factor that into our planning? Is this a patient who is perhaps preparing to get pregnant? We would definitely want to avoid medications as much as possible in that kind of situation and be very aware of it. Other factors, is this somebody who is on many other medications? Can we combine things? Is this somebody who has the ability to learn some non-pharma techniques to manage the headaches? So then we also think about acute medication versus preventive, right? And acute medications used to be called abortive treatments. In the US, at any rate, I'm interested to hear how you all refer to these. We call them acute medications. And we speak about migraine now as migraine disease, not migraine headache. So there have been some semantic changes that I think really are intended to decrease the stigma of migraine, which it really is very challenging for patients who have migraine. Many of their coworkers, family members, friends will say, oh, it's just a headache. It's not. It's a whole event in the brain. And I actually have one pathophysiology slide I put into this deck to show you because I love it. It just is so clear. So we'll take a look at that in a minute. But at any rate, most patients are going to need some kind of acute treatment, and it's often a medication as well as a preventive treatment depending on the frequency of the headaches. We talk a lot now about shared decision making. So in other words, if I were seeing someone with migraines and I finished my evaluation and had a sense of what the diagnosis was, what I thought would be appropriate treatment, I might present that to the patient and then get his or her feedback about what would be comfortable, what that person would like to do. Many people seek out my care because they know that I am not, you must take this drug, this is the only thing, but rather combination. It doesn't have to be binary. And I use that phrase a lot. It doesn't have to be one or the other. And oftentimes combining treatments, non-pharma and pharma, can lead to better outcomes for our patients, in my opinion. So the CGRP antagonists are very interesting, right? Calcitonin gene-related peptide, for those of you who are less familiar with the migraine medications, this neuropeptide has been identified specifically as one of the triggers that can set off the whole migraine cascade. I'm going to show you a slide, a picture of where CGRP is found. It's located and released from the meninges specifically in response to a whole cascade of events that will follow cortical spreading depression, right? And basically it affects migraine by tripping off, among other locations, into the trigeminal cervical complex, which sets up both the headache as well as muscle pain. And I want you to remember this as we continue to talk, because this is important for the EMG biofeedback that we will be discussing. Migraine patients report tightness in their neck, their shoulders, and their heads. And while some of it is intracerebral, they also have extracerebral changes as a manifestation. And so by addressing this holistically, as Dr. Shah said, we may be able to interrupt the pain loop and change the response to their treatments for the better. So this is the picture I mentioned that I just love. This is by an article by, I think, Peter Goadsby, who's very well respected in the headache community, is the first author on this paper. And I just think this is such a nice picture of the cascade of what happens during a migraine. So basically, whatever the trigger is, sets off these parasympathetic signals to the superior salivatory nucleus. And note that some of them are coming from periaqueductal gray, which is a pain modulating center in the brain, as we all know. Basically, these signals activate these post-ganglionic parasympathetic neurons in the sphenopalatine ganglion. And some of you who treat migraines may have tried doing blocks at that location with lidocaine, which are sort of plus minus. They may help temporarily, but it's not an ongoing, I don't think, useful treatment on a more permanent basis. But these signals, these parasympathetic neurons then project, look where they're going. They're moving right along here, and they activate these meningeal nociceptors and the trigeminal vascular pathway. And so here we are in the meninges, and what happens is that we get this vasodilatation and the local release of these inflammatory molecules, including mast cell degranulation. We all know inflammation as a result. Calcitonin gene-related peptide, there it is, and PACAP38. I am just back from the American Headache Society scientific sessions, which is a very good meeting. If any of you are headache specialist specifically. You may have attended. If so, I wish I'd known so we could have said hello, but perhaps you'll attend next year. The meeting is also available, I think, virtually as well. I'm not sure, but at any rate, I heard some wonderful talks about new targets for PACAP38 that look very exciting. So there are more molecules in development, but as a result of these inflammatory neuropeptides, we get this activation ending up, as I mentioned earlier, in the trigeminal cervical complex. And that's what starts to trigger off the pain at that point. So you can see here that trying to block some of these triggers may actually avoid the pain. So in terms of the monoclonal antibodies, I've learned from Dr. Shah, that arenimab is in fact available in India. That is a calcitonin gene-related peptide monoclonal antibody that blocks CGRP at the receptor. It does not capture the ligand specifically. Galcanezumab, fremanezumab, and intravenous eptinezumab block the CGRP itself. And so there is some variation in response, but all of these drugs, I will say, can be very effective, although we don't have a way at this point to predict who is going to respond. So there can be variation. But for people who are CGRP responders, they can have a very dramatic response. So with these injectables, with the arenimab that I think you all may have available to you for your patients, there are certainly some side effects. Constipation is one of the biggest ones. People can be allergic. The injector, often people find painful. I don't know if in India you have availability, and I'm not sure if arenimab even comes in a syringe, a pre-filled syringe, but you know, for people who respond to the drugs, they will deal with the pain of the injection. Who gets excluded from this? We exclude people who've had a heart attack or a stroke because we don't have safety data around that, although it's probably okay. We also exclude anybody who's planning or considering a pregnancy, right? Because the drugs are very durable, they have a long half-life, and there's no safety data during pregnancy. I'm sorry, my mouse is just really a little sensitive here. We monitor them, we see them every 6 months, although there's no lab testing that needs to be done, but they are relatively new drugs overall. So we keep an eye on the patients, make sure that the drugs are still effective, and then dosing. One of the molecules that we have available that isn't available in India, the fremanezumab, can be dosed quarterly, and the infusion eptinezumab can also be a quarterly infusion. So that really is nice because people don't have to think about treating as often. So the GPANTs are the CGRP antagonists. 2 of these actually have been approved as preventives, atogepant and rimagepant. One is a daily pill. The other one, rimagepant, is an every other day dissolved tablet. Oftentimes patients who don't want to do anything that involves a needle will prefer one of these. But you know, again, what do we want with our migraine patients' overall well-being? We want them to not have to think so much about the migraines. So having to take a pill every day or every other day is different than a once-a-month injection for sure. The nice thing about some of these drugs, the oral agents, is that if somebody does want to get pregnant within 6 months, they could just stop the drug. It would be out of their system relatively shortly. The half-life isn't that long. And so that may be a good possibility. And some of them can interact with other medications. They're CYP3A4 inhibitors. So you have to be a little bit careful about certain medications as well. So what are the non-pharmacologic options? Acupuncture is something that I personally advocate. I've studied this. I work in the integrative medicine clinic at Mass General Brigham, and we do have wonderful acupuncturists there. Craniosacral therapy is another option. This is a kind of hands-on treatment that involves regulation of CSF flow. I actually published a small case series with our craniosacral therapist of 3 patients that we treated for post-concussive headache with craniosacral therapy. It's not massage. It can be, again, quite effective. Chiropractic care is another option for patients. We did the IMPACT study, which some of you may be familiar with, looking at a personalized approach, trying to treat some of that muscular spasm and pain, neck pain, shoulder pain in patients with migraine, in women with migraine. And we did see signal both in feasibility of the study, but also we met one of our secondary aims in terms of migraine days, which is really interesting. And that is now an NIH 2-site study where we'll be looking to see if, number one, feasibility, if we can recruit patients, and if we can standardize a chiropractic protocol that can be delivered across number of populations with fidelity. So that's quite interesting. Mindfulness, including biofeedback, which is a first wave therapy, second wave therapies, such as MBSR, mindfulness-based stress reduction, and then third wave therapies, including acceptance and commitment therapy, which is a form of what's called cognitive diffusion, can be very effective. And these are all really interesting, right? Because again, harking back to that idea that we may be able to change or evoke neural plasticity with non-pharmacologic treatments has a lot of traction now. Functional MRI imaging is going to be able to show us what that actually looks like, dynamic brain imaging. But at this point, the metrics that we're gathering are certainly supporting these kinds of treatments and evidencing them. There are various kinds of stimulators that I personally think have a plus minus response. And some patients find them very painful, but some people do note improvement. And then we have EMG biofeedback, which we will continue to talk about through this discussion today. So harking back to this, migraine patients often have neck and head muscular stiffness and tension. What is biofeedback? Biofeedback is a way of learning techniques, getting some kind of body response that demonstrate to the person who is practicing the technique that there is some kind of change. Okay, so one example is teaching people to change the temperature of their hands. And this can be done for anxiety, it can be done for migraine, it can be done for a number of different pain activities. So let me tell you first what happens, and then I'll tell you how I think it works. Basically, people will have a temperature probe attached to their finger. They will learn a series of mind-body techniques, and they will actually watch on a computer screen and now on their phone, so this can be delivered remotely, how the temperature in their hands will begin to change. And by focusing on that, think again about that pain loop, drawing attention away from that into seeing this change and getting the feedback from the response. People will actually report that their pain is less. So how can that be helpful with using EMG in addition, measuring muscle tension, and then learning how to use these biofeedback techniques specifically, seeing the response, getting feedback of the response in relaxing the muscles can actually, again, cause this neural plasticity. So it can help with stress reduction, it can help with relaxation, may ultimately decrease migraine frequency. And that's going to be the target of our discussion today. Learning how to do this, is it going to cure the migraines? I don't think so. But who knows? We don't have enough data yet to know the answer to that. And again, we can talk about it. Is there an overall cure for migraines? To date, there is not. But I do think that within the next however many years, we will get closer and closer to that goal. Can we help to manage migraines and people's ability to function by teaching them techniques such as various forms of biofeedback, including EMG biofeedback, absolutely. It is critical that people, in addition to, or perhaps instead of, taking medication to change various brain activation, that we teach them how to cope with the sequela, the components of the migraine, such as the tension and the spasm, and also return to them their sense of agency and autonomy, the fact that they have control over their bodies in these painful, challenging moments. So learning how to use some techniques to change one's own body's response to pain, I think, is very, very important. There's another technique that some of you may be familiar with. It's called progressive relaxation. And I have taught this to people in my office very quickly. It's a technique that you can use for people who have insomnia. And it follows, if you think about it, this same kind of idea, right? Of moving your attention away from the fact that you're lying in bed, unable to sleep, which we all are at some point, by giving you some autonomy over your body. And basically with that, just to give you a very simple description, you lie on your back, you tighten up all your muscles, and you start with your toes, your ankles, your knees, your hips, and you just work on breathing and relaxing each muscle group, progressive relaxation until you get up to your head. And many people report that they can't remember what happened after their hips because they're asleep. I encourage all of you to try this maybe tonight when you're lying in bed and see if it's helpful. So at any rate, we did a small pilot study looking at EMG biofeedback at Brigham and Women's Hospital, which is now merging with Mass General. So we're supposed to call it Mass General Brigham, same place. We studied 84 patients with episodic migraine with a wonderful research team. The patients were between the ages of 18 and 65, and the primary outcome was migraine disability and migraine frequency. What are the effects on those factors? The secondary outcomes are really interesting to me at any rate, in particular, and for the reasons I've described, I think you can see that they are also critical. So migraine-related quality of life, depression, and anxiety. If you can give people back a locus of control over what is happening to them, if you can distract them from the fact that they are in the midst of a terrible migraine by teaching them these biofeedback techniques and using a device that actually gives them, using AI, a virtually delivered technique that teaches them how to do this kind of work in the moment, it pulls that attention, again, away from the other components of the migraine and affects that pain loop so that they begin to feel better. The study was a 2-to-1 randomization using EMG biofeedback versus usual control, and it was a 6-week duration. So, very interesting, and I think this is my conclusion here. The treatment group had a number of findings, but these are the ones that I personally feel are just highly interesting. Statistically significant improvements in pain intensity and in migraine-specific quality of life. And these are metrics, these are scales that have fidelity that can be used from study to measure outcomes. So these have quite a bit of significance. Patients were queried about a number of different things. And, with migraine research, number of migraine days is always important. But what I really think it's not the only factor. And in larger studies, we may be able to see more data. But in the study that we did, these are the key findings that really I just find absolutely fascinating. So I see this as a potentially very promising therapy for episodic migraine, either alone or with medication, harking back to that, it doesn't have to be binary. It doesn't have to be one or the other. Patients really have some choice, and we, as their physicians, have a lot of options for them that are tremendously exciting. I say to people all the time, we are all better on fewer drugs. And the more work that we do that can identify other evidenced safe treatments, the better. So I'm going to stop here, and I am exactly at 25 minutes. Thank you so much for your attention.
Thank you so much, Dr. Bernstein, for the wonderful presentation. I would also request all the audience to please post your questions in the chat box. And now hand over to Professor Dr. B.S. Engel, sir. So, sir, over to you.
Thank you, Professor Bernstein, for covering the important topic of migraine and giving us the important information about the biofeed mechanism. And I think there are some questions from the audience. And that is, the one question is, what group of muscles targeted for EMG biofeed in migraine patients?
I'm sorry, the sound cut out there for a moment. Please repeat.
I'll tell you again. The person wants to know which group of muscles you use for EMG biofeed for migraine patients.
Yeah, so we identified various muscles that are often sources of migraine pain specifically, and that doesn't mean that these can't be adjusted in the future, but certainly trapezius, neck, frontalis are places, temporalis as well. And again, some flexibility with that for sure. So I think that the treatment sites, and Dr. Shah, please add in here, the treatment sites will be adjusted going forward, or can be adjusted going forward, to broaden, and it may be possible that we customize treatments for specific patients.
And the second question, Ravi, of course, you've already covered it in your talk, and that is, what are the benefits of EMG biofeed? Does it need a therapist, or can it be done virtually?
So this can be delivered virtually, which is very exciting.
Is there any other question that anyone would like to ask Professor Bernstein? I suspect this EMG biofeed is the surface CMG. Is that it?
Correct.
True, it makes sense, to use the temporal muscle and these, and I think you've already shown the benefit of this thing. But tell me one thing, can you use it also for people only having the aura and not the headache?
That's a great question. I don't know necessarily that I would prescribe EMG biofeedback for the patients with acephalgic migraines. Something deep is happening in the brain that's triggering that. It's a consequence, right, of the cortical spreading depression. But because there's not really a muscular component to those headaches, I don't know that it would be effective, but it would be a very interesting sub-study to try it. Again, people who have aura alone, it's often so short that we can't treat them with a medication. But if they could use EMG biofeedback in those moments, that may be a very effective treatment.
But what is the longest duration of aura that you have seen in your practice?
So aura by definition is 5 minutes to 60 minutes, but there is something called persistent visual aura that's really very challenging to treat, where people just have it all the time. And the only medication I'm aware of that actually makes any kind of difference in treating that is valproic acid. But there are people walking around with, permanent scotomas, and you'd want to just be absolutely sure that there's no ocular etiology or other etiology.
There's some other questions as well. I think does it help in the treatment of migraine episodes and prevention? That also I think you covered. Which position is best while treating patient with EMG biofeed? Position, I guess they want to know whether the patient is sitting or lying down. What?
I think that, what I would recommend is that patients be as comfortable as possible. And in my experience, people, when they're having a migraine, prefer to be lying down if they can. But, the nice thing about this technique is that it can be used in different settings. So, I would like to think that somebody at work in the office, if they're lucky enough to have some space, could be in a private room, close the door, and use the techniques in that time, in that way. Dr. Shah, can you add in on that?
No, I think, yeah, as you have mentioned, that is correct. That is correct. Nothing further to add.
I have never used, but I think the people have talked even of the use of Botox, for the treatment of migraine. I've never used myself. Have you had any experience with that?
So I'm treating 300 people with Botox, and it is extraordinary when it works. So it's 31 injections, and for those of you who are interested, I encourage you to look at the Preempt 2 protocol, which is the way that we inject. And it covers a lot of these muscles. And I remember talking with our research team when we were, really trying to isolate which muscles would be effectively targeted for EMG biofeedback. So the Botox gets injected into the occipitalis, high paracervical, trapezius, auriculotemporalis area. There's a little kind of a diamond shape of injections, and then the corrugators, the procerus, and then the frontalis. And patients have to demonstrate, in order to get their insurance to pay for it, they have to demonstrate at least a 50% reduction. But I have seen people go from 15 or more migraines a month to 2 or 3 that are easily treatable. In my opinion, these patients are also great candidates for EMG biofeedback. They have such anxiety around the migraines because they've lived through such a challenging time that learning these techniques that, again, as I mentioned, restore some agency and some autonomy to the fact that they can learn how to relax the muscles specifically when they start to tighten up can really be important for them as well. But the onabotulinum toxin A is an incredibly successful treatment for a number of patients.
Thank you, Professor Bernstein. I think now I'd like to hand over to Dr. Srinivas, as the moderator, to carry on with the panel discussion and also take questions from the audience. And I'm quite sure that Professor Bernstein will pitch in as and when needed.
Thank you very much, Professor sir. I think the whole idea of bringing in the biofeedback are the following principles: that it is non-invasive, it is very safe, and it's no side effects, and it stops and reduces the need of medicines and the complementary along with other drugs. It's very, very safe for pregnant women, and you will feel more in the control of your health. With this small, nice preamble, we have the panel discussion going on, and I request Dr. Ghosh, what are the challenges faced while treating a migraine patient, number one? And number two, if you have any case whom we have treated this biofeedback, we'll be interested in learning from you. Thank you very much. Over to Dr. Ghosh.
Thank you. Thank you. I have been using it in migraine quite often, and I think it gets a better response if there is also fibromyalgia. Now, I haven't treated the patient during the acute attacks, and I would like to ask Dr. Bernstein whether you can use it in the acute attacks or not. But when the patient is in a better form, between the attacks, the episodic migraine, if you use it during that time, the patient do respond well. And not only that, the medication will be reduced quite considerably, from the 4 or 5 medicines to 1 a day. There is a very small amount, like clopidogrel 25 milligram, can control or prevent the attacks in future. So that is, if you can continue with the biofeedback on a regular fashion, in every month you use it, every day you can use it, and the response is better, particularly if there is fibromyalgia. Thank you.
Thank you, sir. Any other case that you have treated? Personal experience?
Yes, I have
Something-
used it in migraine. I have used it in
Yeah.
spasticity in stroke patients. I have used it in incontinence. That's very effective. And I use the same method. I got a patient with peripheral neuropathy.
Yeah.
And they also responded to this biofeedback mechanism. And the patient who was not being able to walk, I can see in my own eyes how they can walk properly and move around with the help of a stick. So that are the importance of this particular biofeedback mechanism, where you have no other treatment except physiotherapy, but this mechanism can help the patient to control themselves through the EMG and then can rectify themselves and treat them.
Thank you, sir. The second is Professor Lakshmi Narasimhan. What is your take on the role of conservative non-pharmacological management in the treatment of migraine? Is there a paradigm shift towards non-pharmacological management of migraine? What is your touch on this?
Yes, sir. Thank you, sir. Thank you, sir. Thank you for. See, right now there is a paradigm shift that people are shifting towards non-pharmacological sensory modulation therapies in migraine. And one of the most important facets is the biofeedback, progressive muscle relaxation, and abdominal breathing are several behavioral medicine techniques are proved to reduce the headache. When employed regularly and combined with preventive medications and optimized acute therapy, the quality of life is significantly better than with the medication alone. Biofeedback and progressive muscle relaxations are the most widely accepted non-drug techniques for the control of headache and control and prevention of with benefit being patients painless and non-surgical modalities. The effectiveness have been demonstrated across 25 years of research and well over 100 investigations. Even international guidelines like American Medical Migraine Foundation, after having used biofeedback to develop the ability to recognize reduced tension of the body, will benefit from virtual patient care, have recommended this. These skills aid in preventing, reducing, or stopping a headache.
Thank you, Professor Lakshmi Narasimhan, for your excellence explicitly expressed in your comments. Now, I request Professor Nandan Yadi, the senior neurologist of the Dr. Nandan Yadi, how does EMG work for augmenting the pathophysiology of migraine, especially when we have to look at it from the migraine angle?
So she gave us a very good description about the pathophysiology of migraine. And as far as I am concerned, we do treat adolescents and children with migraine. And the commonest kind of migraine we see in children is the tension type headache, which sort of manifests as headaches. And this is associated with a lot of tension in the muscles around the neck, as was described by Professor Bernstein. And typically the occipitalis, the trapezius, mostly on the neck side, but sometimes frontalis. And these muscles have been used in trials and in studies where the child was given those electrodes on the frontalis or on the occipitalis. And then with the biofeedback, they have found significant improvements. And these account for a large number of patients in pediatrics. So I don't have personal experience because I don't do biofeedback and nor do I primarily treat migraine. I'm more focused on epilepsy. But one thing I believe is that progressive relaxation, and she also showed us the parasympathetic system, whereby that affects the migraine. And other biofeedbacks, other than EMG, other non-pharmacological treatments like yoga and all, which actually sort of improve the parasympathetic tone, may also, and there have been studies that have that migraine has been sort of shown to be alleviated with this. So it's basically relaxation of the muscles, either by whatever non-pharmacological treatment or by EMG biofeedback would be useful in these. And I think that's a therapy which is going to evolve. So thank you, Dr. Bernstein, for your very nice talk and insight into this.
Thank you, Dr. Nandan Yadi. I now come back to once again Dr. Pahari Ghosh of the senior neurologist of the Bellevue Clinic in Kolkata. Sir, how can we integrate EMG biofeedback with the existing migraine treatment? your views on that?
Well, we can do it along with the biofeedback. I mean, using the muscles which are involved in the migraine attacks, particularly the trapezius and frontalis, what Bernstein said, and also the temporalis. If you use the EMG, surface EMG on these muscles and make the muscles relax, then the chances of attacks of headache or severity of the headache will be much less. So that's my view about the surface EMG and biofeedback mechanism.
Your view on the great potential in the treatment of migraine, what is your future thinking in this respect?
Well, it's a very good method by which you can use and reduce the intake of medicines. But using it alone I don't think it will be very helpful. But if you can use this one along with the medicines in a smaller dose, you can control the migraine. And particularly patients with people who are pregnant or planning to have pregnancy, I think this would help the effect of the headache less, and then the patient can tolerate the headache much better instead of taking medicines during their pregnancy period. So this is how it's going to help in pregnancy. If you don't want to have any medicines, with this biofeedback mechanism, incidence and the severity of the migraine attack will be much less, and they can tolerate the headache in those cases. So this is one of the most challenging things that we can expect from this biofeedback mechanism. And second thing is, those people who are averse to take regular medications, this biofeedback mechanism can help them to alleviate some of their headache and pain. Thank you.
So thank you very much, sir. I think we'll come back to Madam Dr. Colleen Bernstein. How does the EMG biofeedback impact auto loop pain, anticipatory anxiety in migraine? Your thoughts, please, Dr. Caroline.
Yes, thank you. So I'm going to just give you my opinion because I don't know the answer. We don't have data yet specifically, but I think again, it's returning that locus of control to patients and taking them out of what we call the sick role, right? They are the person who is being impacted by the migraine. They are learning how to use a technique that will improve relaxation, that will potentially change the way pain is being modulated in the brain. And that's a ripe area for further studies. And it gives them back a sense that they can change things. One thing that I wanted to mention in response to a comment a few minutes ago is that Dr. Scott Powers, who is a wonderful pediatric headache specialist, has studied biofeedback, not specifically EMG biofeedback, but other forms of biofeedback in children, and compared it to medications and actually found that biofeedback was more effective than propranolol or topiramate in treating children with migraines, which doesn't really surprise me that much. I think there's so much of migraine that is driven by inflammation, and inflammation can be triggered, as we all know, by anxiety and by stress. Cortisol goes up, inflammation starts, and that triggers off that whole cascade that I showed you in that beautiful graphic. So learning biofeedback, I think, has tremendous potential, targeted biofeedback for changing one's response to pain, anxiety, stress, and then some of the other uses that we heard a few moments ago from colleagues, using it for urologic etiologies, gastrointestinal as well. So I think, this first wave mindfulness treatment combined with being able to do this remotely using artificial intelligence is just tremendously exciting. And, maybe we'll be having this conversation a year from now and have quite a bit more data to share.
That's lovely. I think the experience scores over the experts, and experts are still looking out for a double-blind crossover trial on this. But nonetheless, does JOGO help with urinary retention and spinal injuries, specifically lumbar? What's your view on that? How does EMG biofeedback impact the auto loop?
I think I will just pass that question because I don't deal with that.
Okay, then I think the other thing which is very, very
With your
good.
permission, sir, with your permission, can I?
Please.
Sir,
Yeah,
I have
please,
used,
please.
sir, I have used for urinary incontinence and I am attached to. Sir, I've used for urinary incontinence. I am attached to a urology clinic. I found it very useful, sir. Especially urinary incontinence. It is very good, and especially post-spinal injury, sir.
Dr. Lakshmi, I think it was, I didn't say, your professor and head of the department in Sri Ramachandra Medical College after being a director in the Institute of Neurology, Madras Medical College. See, the question to you will be, are there any potential patient benefits or specific criteria most appropriate for using EMG BF in migraine? What's your view on that?
There are enough papers on EMG biofeedback in patients with episodic migraine with or without ARA. The second thing is, there are papers on chronic migraine also. There are enough papers on tension type headache. All in these indications, the biofeedback has improved the quality of life. It has reduced the necessity of medications, and it has all these results show that they are all statistically significant, sir. In episodic migraine, chronic migraine, and tension type of headache. In episodic migraine, both with and without ARA. Thank you, sir.
It's really a touch of a class of a person to a class of people with migraine. I think you're beautifully expressed. Now, I come to Dr. Anshu Rostagi, Senior Neurologist of Sri Gangaram Hospital, New Delhi. Sir, do you anticipate any challenges for using EMG BF?
As we had all listening for quite some time, for last 30 to 45 minutes, I think it's a very good novel way of treating migraine. And I think it has to be used in combination with other therapies. You cannot use this singularly. And so there is a lot of data on biofeedback in various kinds of headaches, tension, migraines, and it really improves the quality of life. The main problem would be, I think, what does this mechanism has done is that it is AI driven and it's done on the video. So logistically, it will be very easy for patients who are even at distances, they can use it. So I think the major challenge may be the cost. So I think Jogo would be able to tell us the cost involved, because in India, people are very, very financially this thing. So I think the cost would be the major factor which will drive this therapy. But I think it's a very good addition to the armamentarium of treatment because people don't want to take oral medication nowadays. They want non-invasive ways. So I think that would be really good, and especially good for women, because most of the women, the medication that we use for migraine prophylaxis, they have this side effect, whether you take sodium valproate, topiramate, or for that flunarizine. So they wanted the women want a treatment which is non-invasive. So I think combination therapy would be the way forward, and I think the financials would really tell us the way how the therapy would do. And I think the use of video biofeedback would really make it much, much more attractive, and people at distance can use the treatment.
Continuing with this, can EMG biofeedback be used in cardiac and epileptic patients with migraine? What is your view on that?
I think Professor Colin Bernstein will be able to tell better, I think, than me.
So we'll request Dr. Colin, please.
Yeah, I have no idea. I'm sorry, I just don't know the answer to that one.
If I may come in.
Yes, Dr. Nandan.
Okay, so about this for epilepsy, I can talk about epilepsy.
Yeah.
So the EEG biofeedback, not EMG biofeedback. EEG biofeedback for epilepsy has been used, and there are several papers which talk about changes in EEG following these biofeedback mechanisms. And there has been significant evidence in the past, especially from the German groups, who have shown that it is effective. So it's currently under investigation as a lifestyle approach, besides others like yoga, culinary medicine, and all at the Cleveland Clinic, which we are researching currently. And we will soon be able to give you some interim data in the year or two. So there are a variety of modulations that can take place in terms of lifestyle in chronic disorders, which are related to stress and inflammation, and sometimes even some, temporary gene expressions. And these are all being studied at the current moment. So we will wait for it. There has been sketchy data on that, but we'll wait for more robust data coming out from the Cleveland Clinic.
Can I add something?
Please. Yeah, please.
So we have been using EEG biofeedback for using tension type headaches for a long time. And I think most of the this kind of biofeedback were being used by psychiatrists also for the last couple of years. So we have had used EEG biofeedback for treating tension type headaches, but this EMG biofeedback is something that we haven't used before for headaches.
Thank you. I think, Dr. Nandanyadi, we are just going to have the last questions from this. That is can EMG biofeedback be used in pregnant patients with migraine? I mean, what is your thought? It's open to all of us.
I think it is a safe mechanism because we are using even the other neuromodulation devices which are available in pregnancy. The various neuromodulation devices, they're also safe in pregnancy. As far as the EMG biofeedback is concerned, I think I don't know whether there is FDA approval for use in pregnancy.
Well, there are papers which published, and it can be used in pregnancy, and definitely it helps in reduction of the attack of epilepsy.
Dr. Kalin, what is your view on this pregnant women?
I think it's probably fine. It's always tricky with pregnant women. There are some obstetricians who really recommend against even using the stimulators for them, but this is different. And the EMG biofeedback, and it is superficial, so I think it is a safe technique, and I would validate that.
Thank you. I think Shiva Natraja has got the FDA approval for this because we have already mentioned it in the beginning itself. I said it's very safe for pregnant women. I think FDA has just given the permission. But one thing that I want to just know from you, Dr. Kalin, what does the American Foundation state about the EMG biofeedback?
So as far as I know, the American Headache Society guidelines don't mention it specifically, but they certainly address using non-pharma with pharma therapies, and they address the need and the efficacy of combining biofeedback with other kinds of treatments, but it's not specifically mentioned per se. That said, I expect as it gets wider use, this will change.
So I think from India, Dr. T.C. Ramakrishnan brought out a lovely case. It's a 50-year-old female with a housewife of mother of 2 children, suffered with headache of 17 years duration with no focal neurological deficit. And then the Jogo was done, graph and electronic placement was all done with a perfection. And it was done in the frontalis muscle and relaxation with a pre-session. And the name of the patient was Uma Mageshwari. And B frontalis sitting with the support. And the frontalis actually the post-session. Uma Mageshwari had a frontalis relaxation, and B frontalis sitting with support. And really what happened is she was getting it in always the whole progression of 12 sessions of Jogo therapy, including relaxation, strengthening, exercise, and myofascial release. The patient did not get any new episodes of migraine and as well as headaches due to strengthening exercises and lifestyle modification instructions. The patients felt active and brisk. Patient became very socialized and start to travel without any hesitations and the fear of migraine attacks. I think this has really given a very good, with a conclusion that yoga therapy provides real-time feedback, muscle relaxation to the patient, which enables the patient to promote the relaxation of frontalis, temporalis, and upper trapezius muscles. The patient feels completely relaxed, and in the last 1 month, she did not get any new migraine symptoms. She started to socialize herself, and so the conclusion is yoga feedback therapy helps to reduce the migraine consistently. I think we have just touched the greatness of this particular procedure, giving a complete relief, and especially from the migraine.
Thank you,
think
Professor.
the time is the most important factor, and people have used 30 minutes and 60 minutes. This is to Carlin Bernstein. You prefer 30 minutes or 60 minutes? In whom you use 30 minutes, in whom you use 60 minutes?
Thank you, Professor Srinivas. I think this will be the final answer.
Yeah. Yes,
So
sir.
I think treatment always has to be individualized. And, I don't have clear parameters in terms of time. At this point, I will say that patients and their attention and their ability to stay with something generally is relatively short unless they are experienced mindfulness practitioners. But it's like it's like yoga, which somebody mentioned a minute ago. If you can do 10 minutes of yoga poses, that may affect some autonomic change and some neuroplasticity. And so even a short duration, I think setting a realistic goal for people is just extremely helpful. So I'll end there.
Thank you very much. I now request the vote of thanks by Charles.
Yes.
Good evening, doctors. I'll just take less than 100 seconds. Thank you so much to all of you for your time, sharing your experience, etc. First, a big thanks to Professor B.S. Singhal. Thank you so much, sir, for sharing and your opening remarks. We really feel honored. We also thank Professor A.B. Srinivasan for moderating the session and ensuring that everyone is engaged. We thank Professor Carolyn Bernstein for an expert presentation on the breakthrough treatment in migraine management. A special thanks to Dr. Pari Ghosh, Dr. Andanya Ali, Dr. Professor Lakshmi Narasimhan, Dr. Anju Radogi, and all the delegates who are there. I'll just take just less than 5 seconds to just show you a few things which probably we have not shared till now. It'll be less than a minute. So, So can you see the slide? So Jogo is about digital therapy. We use it not only for treatment of neurological disorders, but also for pelvic as well as musculoskeletal condition. Basically, as Dr. Ruchi mentioned, we are a US-based digital therapeutic company. We have operation in 4 countries. We are a J&J lab, Innovation J Labs. When you compare the old EMG and the new Jogo EMG, it is portable, non-invasive, digital. And it's an AI device with wearable sensor applying the science of EMG biofeedback, facilitating neuroplasticity. It is also having FDA approval. Basic science is neuroplasticity, as you all know. We treat in neurology the following conditions, as well as in urology, as well as in gastroenterology and MSK. We are accredited by US FDA for a breakthrough device, which means there's no parallel to Jogo in low back pain, chronic low back pain. We also are JC accredited as the world's first digital rehab center under ambulatory care. We have clinical research partnership with Harvard as well as Mayo. In India, we are present in 10 cities for the last 6 months, and we are present in 25 hospitals. We don't sell the device. We are, in partnership. And in case there is any interest on Jogo, you can contact us on the following numbers. To all the doctors who are registered, about the device as well as how this device works, we'll be sending a link in the next 2 days. Thank you so much, and looking forward to more such meetings. Thank you.
Thank you, everybody, for this wonderful session. Just want to mention that we do have permission to share the patient information.
Dr. Ruchi, you can conclude.
That one case that we mentioned. Once again, I want to thank Dr. Bernstein for sparing the time today, and all the wonderful doctors from India for participating in this session and just adding to the body of knowledge.